Howdy, my name is Aaron Boster, Systems Medical Chief of Neuroimmunology and Director of the Ohio Health MS Center at Ohio Health Physicians Group in Columbus, Ohio. Welcome to this video-based educational activity on multiple sclerosis, focusing on updates from the recent joint ECTRIMS-ACTRIMS meeting in Paris, France.
The following audio is part of a certified educational activity titled Potential Clinical Implications of the Latest Data on Approved and Emerging Disease-Modifying Therapies for Multiple Sclerosis, a recap from Paris. Access the entire activity and complete the post-test at www.peerview.com/SQK. Downloadable slides and practice aids are also available.
Before we delve into all of that data, I would like to begin by discussing the 2017 proposed revisions to the McDonald diagnostic criteria for MS, which were also presented at the MS Paris 2017 meeting. The 2017 revisions to the McDonald diagnostic criteria for MS can be summarized as follows. Number one, in a patient with a typical clinically isolated syndrome, fulfilling the clinical and MRI criteria for dissemination in space, and no better explanation for the clinical presentation, demonstration of CSF with unpaired oligoclonal bands allows an MS diagnosis to be made. This is in addition to the old way, using the 2010 revised McDonald criteria, that would require further MRI evidence of dissemination in time. Number two, symptomatic and asymptomatic MRI lesions can now be both considered in the determination of dissemination in space or in dissemination in time, as compared to the 2010 revised criteria, which only allowed asymptomatic lesions. Number three, cortical and juxtacortical lesions can now both be used in fulfilling MRI criteria for dissemination in space. In the 2010 McDonald criteria, cortical lesions were not allowed to be used and would not fulfill criteria for dissemination in space. Now they do. Number four, aside from the removal of the distinction between symptomatic and asymptomatic lesions, and the fact that cortical lesions are now allowed to be used, the diagnostic criteria for primary progressive MS is the same in 2017 as it was in the 2010 revised McDonald criteria. Number five, at the time of diagnosis, a provisional disease course or phenotype should be specified and periodically reevaluated based on accumulated information. This is in addition to the 2010 criteria. Now let's turn our attention to some updates on the various approved interferon beta preparations and Glatiramer acetate. In the REFLEX study, clinically isolated syndrome patients were randomly assigned to receive subcutaneous interferon beta 1A, 44 micrograms thrice weekly, once weekly, or placebo for a period of 24 months. Upon conversion to clinically definite MS, patients switched to open-label SubQ interferon beta 1A thrice weekly. In the REFLEXION extension study, all placebo patients were switched to subcutaneous interferon beta 1A thrice weekly in a delayed treatment arm. Subcutaneous interferon beta 1A patients continued their initial regimen up to 60 months. At the 7th Joint ECTRIMS-ACTRIMS meeting, Dr. Friedman and colleagues presented the results of a post hoc analysis of the REFLEXION study. The results of this analysis showed the presence of baseline GAD lesions was associated with a lower chance of remaining NEDA 3 after a 3-month MRI compared to those who had no GAD at their baseline. In addition, early treatment with SubQ interferon beta 1A was associated with a higher chance of achieving NEDA 3 beyond the 3-month MRI as compared to the delayed treatment arm, regardless of baseline MRI GAD status. Moving our attention to pegylated interferon beta 1A, the efficacy, safety, and tolerability of SubQ pegylated interferon beta 1A, 125 microgram, given every other week, was established in the ADVANCE trial, a phase 3 investigation. At the MS Paris 2017 meeting, Dr. Newsom and colleagues presented the results of a post hoc analysis which showed newly diagnosed treatment-naive patients with relapsing MS had improved clinical and MRI outcomes when administered continuous pegylated interferon beta-1a every 2 weeks as compared to a delay in treatment initiation. These results were generally consistent with the non-newly diagnosed patients and the overall intent-to-treat population in the ADVANCE trial. In addition, the first interim analysis of the Phase 4 POP study, looking at pegylated interferon every 2 weeks, was also presented in Paris. The 5-year observational POP study provides an opportunity for us to explore the long-term safety and effectiveness of pegylated interferon beta-1a every 2 weeks in the real-world setting. The results of the first interim analysis of POP showed the safety profile of pegylated interferon beta-1a every 2 weeks was consistent with that previously reported in the ADVANCE trial, and no additional safety signals were observed. The proportion of treated patients who were relapse-free was high. Treatment-naive patients were more likely to experience AEs and discontinue treatment due to injection site reactions and flu-like symptoms as compared to those who had more experience with the therapy. Treatment-experienced patients were more likely to discontinue treatment due to lack of efficacy. Moving on, let's discuss some new data on Glatiramer acetate. The CONFIDENCE study was a Phase 4 open-label global trial with a 6-month core phase and a 6-month extension phase. Patients were randomly assigned 1-to-1 to receive either Glatiramer 20 milligrams or Glatiramer 40 milligrams. The primary endpoint was medication satisfaction over a 6-month time frame. Secondary endpoints included convenience perception and symptomatic changes. Treatment adherence was an exploratory endpoint. At the 7th Joint ECTRIMS-ACTRIMS meeting, Venziano and colleagues presented the 6-month results of the CONFIDENCE study, which showed patients treated with Glatiramer 40 reported significantly higher medication satisfaction than those treated with Glatiramer 20 over 6 months. In addition, patients reported significantly higher perception of convenience, reduced impact of fatigue on patient activities, higher adherence, and better mental health with Glatiramer 40 as compared to Glatiramer 20. Lastly, the AE profile was consistent with previously reported data. In summary, I am most struck by the newly revised 2017 McDonald criteria to diagnose multiple sclerosis. It has already assisted me multiple times in clinical practice, and I'll give you a quick example. The week after returning from the ECTRIMS meeting, I saw a gentleman who suffered a transverse myelitis affecting his thoracic spinal cord. He had a clinically isolated syndrome. We did an MRI of his brain, and he had 4 lesions. They were all periventricular. Because we are now allowed to consider symptomatic and asymptomatic lesions, he met dissemination in space criteria. He did not meet dissemination in time. However, we performed a lumbar puncture, and he was found to have multiple unpaired oligoclonal bands. The presence of the unpaired bands takes the place of dissemination in time. And based on the new diagnostic criteria, we were able to diagnose him with relapsing MS at that time. As a result, we were able to start him on therapy early. Evidence that the new revised criteria are already helping us in clinical practice. We also saw new data on approved oral disease-modifying therapies at the 7th Joint ECTRIMS-ACTRIMS meeting in Paris, France. So, let's begin by discussing some of the recently presented data on Teriflunomide from the core and extension studies of TEMSO and TOWER. The randomized Phase 3 TEMSO and TOWER studies showed Teriflunomide 14 milligrams daily to be significant in its reduction of annualized relapse rate and 12-week confirmed disability worsening in patients with relapsing MS as compared to placebo. At the MS Paris 2017 meeting, long-term disability outcomes in subgroups of patients defined by demographics and by baseline characteristics from the pooled data set of the Phase 3 TEMSO and TOWER trials and their extension studies were presented. The results of these analyses show the percentage of stable and improved disability as measured by EDSS during the overall period of treatment with Teriflunomide 14 milligrams daily remained high across all studied subgroups. Another pooled analysis of the TOWER and TEMSO core and extension data showed low-grade lymphopenia was infrequent, with no reports of high-grade lymphopenia. Infection rates in patients treated with teriflunomide 14 milligrams daily were similar in the population with grade 1 and grade 2 lymphopenia as compared to those without lymphopenia. Collectively, these data demonstrate a limited impact of teriflunomide on protective immunity and further support evidence that immunomodulatory rather than immunosuppressive mechanisms of action are at work. In addition, long-term data showed, in terms of cognitive outcomes, teriflunomide 14 milligrams daily significantly improved the PASAT-3 performance versus placebo over 96 weeks in the TEMSO core trial. This effect was also maintained over the course of the extension study. Moreover, a significant association of early brain volume loss with long-term cognitive changes was observed, suggesting that brain volume loss earlier in the disease course predicts long-term cognitive function. Slower rates of brain volume loss over 2 years were associated with longer-term PASAT-3 improvements versus the group with greater rates of brain volume loss at 5 years in the TEMSO population, core plus extension, regardless of the treatment allocation. Lastly, new data from the topic core and extension studies were also presented. In the phase 3 topic trial, teriflunomide significantly reduced the risk of conversion to clinically definite MS in patients after experiencing their first clinically isolated syndrome suggestive of possible MS. At the MS Paris 2017 meeting, data on the relationship between cortical gray matter atrophy and the risk of conversion to clinically definite MS was presented. The results of this analysis showed teriflunomide 14 milligrams demonstrated a statistically significant effect on reducing cortical gray matter volume loss versus placebo. A significant association of early cortical gray matter volume loss with long-term clinically definite MS was also observed, suggesting that cortical gray matter volume loss earlier in the disease course predicts conversion to clinically definite MS. Now let's shift our attention to some of the more recently presented data on dimethyl fumarate. Dimethyl fumarate demonstrated strong efficacy and favorable benefit-risk profile in patients with RRMS in the phase 3 DEFINE and CONFIRM trials, as well as the associated ongoing extension study ENDORSE. At the 7th Joint ECTRIMS-ACTRIMS meeting in Paris, the integrated analysis of DEFINE, CONFIRM, and ENDORSE showed that over approximately 8 years, annualized relapse rates remained low in both newly diagnosed patients treated with dimethyl fumarate in DEFINE and CONFIRM and ENDORSE, and those who were treated with placebo in DEFINE and CONFIRM and then later switched to dimethyl fumarate when they entered ENDORSE. In fact, the adjusted annualized relapse rate was significantly reduced in placebo patients after switching to dimethyl fumarate. Lastly, EDSS scores also remained stable over 8 years, with greater than 90% of patients maintaining walking abilities after 8 years of treatment. Another integrated analysis of DEFINE, CONFIRM, and ENDORSE shows absolute lymphocyte counts were closely correlated with CD4 and CD8 T-cell subsets, indicating that lymphocyte subset monitoring is not necessary for patient safety vigilance. Absolute lymphocyte counts followed a consistent pattern of decline within the first year and generally remained stable thereafter, regardless of category of lymphocyte decline. Low incidence of serious infections, opportunistic infections, and malignancy were observed, even when stratified by ALC or T-cell subset. Data on dimethyl fumarate from the real-world EFFECT study was also presented in Paris. EFFECT was a retrospective, multi-center, international, single-time point medical record review studying greater than 1,700 patients with relapsing remitting multiple sclerosis, evaluating the effectiveness of dimethyl fumarate and other disease-modifying therapies. An analysis of this study showed treatment with dimethyl fumarate was associated with a significantly higher proportion of relapse-free patients and lower annualized relapse rate compared with Glatiramer acetate at 12 months. A separate analysis of this study showed treatment with dimethyl fumarate demonstrated no difference in the risk of relapses and annualized relapse rate compared to treatment with Fingolimod. Let's turn our focus on some key new data presented on Fingolimod. Paradigms is an up to 2-year, double-blind, double-dummy, active-controlled, parallel group, multi-center study evaluating the efficacy of Fingolimod versus intramuscular interferon beta-1a in pediatric patients with multiple sclerosis, aged 10 to less than 18 years at randomization. The results of this study showed Fingolimod significantly reduced relapse rates, MRI endpoints, 3-month confirmed disability progression, and brain atrophy from baseline when compared to interferon beta-1a in pediatric patients with MS. The safety profile of Fingolimod was consistent with that seen in the adult clinical trials. Moreover, more AEs were reported with the intramuscular interferon beta-1a group. Additionally, a new analysis of the FREEDOMS trial showed a strong correlation between neurofilament levels and key measurements of MS disease activity. This showed that neurofilament, which is a biomarker of neuronal damage measured in a blood sample, could, in the future, potentially serve as an endpoint for phase 2 clinical trials in MS. Moreover, blood neurofilament levels were shown to be statistically significantly lower in patients receiving Fingolimod compared to placebo at 6 months, demonstrating an early effect of the drug on disease progression. I personally am most excited about the data that was presented on neurofilament. We desperately need a biomarker to tell us when a patient is stable or when they're active and whether or not they're responding to a drug. And this early data on neurofilament is extremely encouraging. Data on approved monoclonal antibodies also continues to accumulate, as evidenced by the number of abstracts presented at the 7th Joint ECTRIMS-ACTRIMS meeting in Paris. Let's start this section by discussing some of the key data on natalizumab that was presented, beginning with the STRIVE study. The STRIVE study investigated cognitive impairments as measured by the single-digit modality test, health-related quality of life measured by the Multiple Sclerosis Impact Scale 29, and work capacity, measured by Work Productivity and Activity Impairment Questionnaire, in JC virus antibody negative cohort, initializing natalizumab early in their disease course. Data from this study presented at the MS Paris 2017 meeting showed that after 2 years of natalizumab treatment, patients exhibited significant improvements from baseline in their single-digit modality cognitive scores. Similarly, patients exhibited significant improvements from baseline in their MSIS-29 physical score and quality of life scores. In addition, patients also showed improvements from baseline in work capacity in terms of hours missed from work due to MS and daily activities affected by MS. Data from the ASCEND trial were also presented. ASCEND was a multi-center, randomized, double-blind, phase 3 trial of natalizumab-naive patients diagnosed with secondary progressive multiple sclerosis at least 2 years prior with disability progression unrelated to clinical attacks in the year prior. Patients received IV 300 milligrams of natalizumab or placebo for a period of 2 years. At the 7th Joint ECTRIMS-ACTRIMS meeting, Giovannoni and colleagues presented data from a post hoc area under the curve analysis indicating that natalizumab significantly improved the overall disability experience for walking and upper limb function compared to placebo in SPMS patients. Consistent with the primary endpoints of ASCEND, natalizumab treatment effects were greater for upper extremity function. In the CARE-MS1 and 2 studies, 2 courses of alemtuzumab demonstrated significantly greater improvements on clinical and MRI outcomes versus subcutaneous interferon beta-1a over 2 years in patients with active RRMS who are treatment naive and had an inadequate response to prior therapy, respectively. In a recently completed 4-year extension study of these trials, patients originally treated with alemtuzumab could receive as-needed alemtuzumab retreatment at 12 milligrams per day on 3 consecutive days, at least 12 months after their previous course, or another disease-modifying therapy if they suffered a relapse or had 2 new spots on their MRI. In addition, patients initially treated with subcutaneous interferon beta-1a in the core CARE-MS1 and CARE-MS2 studies discontinued that therapy and initiated alemtuzumab 12 milligrams for 2 courses, baseline 5 days and 12 months later 3 days, in the extension study. They could also receive as-needed alemtuzumab retreatment, 12 milligrams a day on 3 consecutive days, at least 12 months after their previous course, or another disease-modifying therapy if they had a relapse or new MRI activity. Patients completing at least 48 months of the CARE-MS extension study could enroll in TOPAZ, a 5-year phase 3B/4 study to further evaluate the durable efficacy and long-term safety of alemtuzumab. So, let's begin by looking at the data from TOPAZ from the CARE-MS-1 cohort. 349 patients originally treated with alemtuzumab in CARE-MS-1 entered the extension. 321 remained on study until the end of year 6 and then entered TOPAZ, of which 299 completed year 7. Alemtuzumab demonstrated durable clinical efficacy in patients with active RRMS who were treatment naive. The majority of patients maintained low annualized relapse rate, showed stabilized or improved disability, and achieved NEDA each year. Alemtuzumab also resulted in a durable suppression of MRI disease activity over 7 years in the CARE-MS-1 patients. A durable reduction in brain volume loss was also observed with alemtuzumab treatment. 59% of patients had no additional treatment course after the 2 initial courses of alemtuzumab through year 7. Alemtuzumab had a consistent safety profile through year 7, and the overall incidence of AEs decreased over time. Now let's look at the data from TOPAZ from the cohort of patients who were treated with subcutaneous interferon beta-1a over 2 years during the CARE-MS-1 core study. 139 patients who were originally treated with subcutaneous interferon beta-1a in the CARE-MS-1 initiated alemtuzumab in the extension study. Of these patients, 122 remained on study and then entered TOPAZ, of which 118 completed year 5. Alemtuzumab demonstrated durable clinical efficacy over 5 years in patients with active RRMS who were previously treated with subcutaneous interferon beta-1a during CARE-MS-1. The majority of patients maintained a low annualized relapse rate, showed stabilization or improvement of disability, and achieved NEDA in each year after initiation of alemtuzumab. Alemtuzumab also resulted in a durable suppression of MRI disease activity over 5 years in patients who were previously treated with subcutaneous interferon beta-1a during CARE-MS-1. 71% of patients had no additional treatment after 2 initial courses of alemtuzumab through year 5. Alemtuzumab has a consistent safety profile through year 5 in patients previously treated with subcutaneous interferon beta-1a, and the overall incidence of AEs decreased over time. So let's turn our attention to the data of TOPAZ from the CARE-MS-2 cohort. 393 patients originally treated with alemtuzumab in CARE-MS-2 entered the extension. 338 remained on study until the end of year 6, and 336 enrolled in TOPAZ, of which 317 completed year 7. Alemtuzumab demonstrated durable clinical efficacy in patients with active RRMS who had inadequate response to prior therapy. The majority of patients maintained a low annualized relapse rate, showing stabilized or improved disability, and achieved NEDA in each year. Alemtuzumab also resulted in a durable suppression of MRI disease activity over 7 years in patients with active RRMS who had inadequate responses to prior therapy. A durable reduction in brain volume loss, 0.19% or less annually, was seen from year 3 through year 7. 47% of patients had no additional treatment after the 2 initial courses of alemtuzumab through year 7. Alemtuzumab had a consistent safety profile through year 7, and the overall incidence of AEs decreased over time. Now let's look at the data of TOPAZ from the cohort of patients who were treated with subcutaneous interferon beta-1a over the 2 years of the CARE-MS-2 core study. Alemtuzumab demonstrated durable clinical efficacy over 5 years in patients with active RRMS who were previously treated with subcutaneous interferon beta-1a during CARE-MS-2. The majority of these patients also maintained a low annualized relapse rate, showed stabilization or improved disability, and achieved NEDA each year after initiating alemtuzumab. Alemtuzumab also resulted in a durable suppression of MRI disease activity over 5 years in patients who were previously treated with subcutaneous interferon beta-1a during CARE-MS-2. Alemtuzumab also durably slowed brain volume loss in the absence of continuous treatment in patients who were previously treated with subcutaneous interferon beta-1a during CARE-MS-2. Alemtuzumab had a consistent safety profile through year 5 in patients previously treated with interferon beta-1a, and the overall incidence of AEs decreased over time. These findings are consistent in demonstrating greater improvements in outcomes based on alemtuzumab versus subcutaneous interferon beta-1a over the 2 years of the CARE-MS-1, and durable improvements in alemtuzumab arm over 5 years in the absence of continuous treatment. Moving on, let's look at some updates on daclizumab. In the DECIDE trial, significantly more patients treated with daclizumab 150 milligrams achieved NEDA as compared to intramuscular interferon beta-1a over 2 years, with the benefits being more pronounced between weeks 24 and 96. In the 7th Joint ECTRIMS-ACTRIMS meeting in Paris, Giovannoni and colleagues examined the influence of baseline characteristics on achieving NEDA in patients receiving daclizumab versus interferon beta-1a in DECIDE. The results of the analysis demonstrated that daclizumab has greater benefit on achieving NEDA versus intramuscular interferon beta-1a across clinically important subgroups, with a higher odds of achieving NEDA being observed for lower EDSS and lower MRI burden at baseline. Additional data on daclizumab shows the effects of clinical outcomes and brain volume change were maintained during prolonged daclizumab treatment, up to 6 years, in the EXTEND study, and patients who switched from interferon beta-1a in DECIDE to daclizumab in EXTEND showed improved outcomes over a 3-year period on daclizumab treatment. In the DECIDE-EXTEND combination treatment period, in which some patients received daclizumab for greater than 5 years, the incidence of AEs remained stable when evaluated in 1-year intervals. Despite the addition of autoimmune hemolytic anemia as a new safety risk, the safety profile remained consistent with previous observations, and together with EXTEND efficacy data, supports a continued favorable long-term risk-benefit profile of daclizumab in relapsing MS. Now let's shift our focus on to ocrelizumab. Several updates from the OPERA-1 and OPERA-2 trials, which compared ocrelizumab with subcutaneous interferon beta-1a in patients with relapsing MS, were presented at the 7th Joint ECTRIMS-ACTRIMS meeting in Paris. For example, pooled data from the OPERA-1 and 2 studies showed ocrelizumab was associated with improved visual outcomes as assessed by low contrast letter acuity tested in patients with relapsing MS, particularly in those with visual impairment at baseline, compared to interferon beta-1a. Pooled data from the OPERA trials also showed that ocrelizumab reduces disability progression independent from relapse activity in patients with relapsing MS. Moreover, subgroup analysis showed the treatment benefits of ocrelizumab versus interferon beta-1a as measured by annualized relapse rate and the proportion of patients achieving NEDA status was maintained across all subgroups and strata and consistent in the findings of the overall pooled OPERA-1 and OPERA-2 populations. Looking at updates from the ORATORIO trial, we saw the significant and clinically meaningful benefit of reducing disability progression seen with ocrelizumab in patients with primary progressive MS persists and is durable with ongoing treatment. Ocrelizumab treatment lowered the risk of progression of upper extremity disability, as measured by the 9-hole peg test compared to placebo in patients with PPMS. Lastly, the updated safety profile in the ocrelizumab MS all-exposure population is generally consistent with that seen during the controlled treatment period in the relapsing MS and PPMS populations. Importantly, the rate of malignancies in ocrelizumab-treated patients remained within the range reported in epidemiologic data and clinical trials of MS. As I review data on monoclonal antibodies in MS, I'm impressed by an evolution in our very expectations of what we get out of these drugs. Years ago, we talked about reducing the frequency of attacks, or reducing the disability progression, or reducing the number of spots on an MRI. These days, we're talking about no evidence of disease activity, confirmed disability improvements, and normalization of brain volume. This is an exciting time to be treating MS. Now let's evaluate data on a few emerging therapies under investigation for the treatment of relapsing MS. Ozanimod is an oral selective sphingosine-1 phosphate receptor modulator in development for relapsing MS. At the 7th Joint ECTRIMS-ACTRIMS meeting in Paris, the results of the Phase 3 RADIANCE Part B and SUNBEAM trials, which compared ozanimod to interferon beta-1a intramuscular, were presented. Both studies were randomized, double-blinded, double-dummy, active-controlled, parallel group studies in patients with relapsing MS. In RADIANCE Part B, patients were randomly assigned 1:1:1 to receive once-daily oral ozanimod 0.5 milligrams or 1 milligram, or weekly intramuscular interferon beta-1a for a period of 24 months. The primary outcome was annualized relapse rate at 24 months. The results of this trial showed that compared to intramuscular interferon beta-1a, both doses of ozanimod significantly reduced annualized relapse rate, the number of new and enlarged T2 lesions, and the number of gadolinium-enhanced lesions. Significantly reduced brain volume loss, cortical gray volume loss, and thalamic volume loss was also observed. In general, ozanimod was very well tolerated. No subjects had a second-degree or higher AV block. The infection risk with ozanimod was comparable to interferon beta-1a. In SUNBEAM, patients were randomized 1:1:1 to receive once-daily oral ozanimod 0.5 milligrams or 1 milligram or weekly interferon beta-1a for 12 months. The results of this trial showed that compared to interferon beta-1a, both doses of ozanimod significantly reduced annualized relapse rates, the number of new or enlarged T2 lesions, and the number of gadolinium-enhanced lesions. Significant reductions were seen in cortical gray volume loss and thalamic volume loss for both doses of ozanimod, and for total brain volume loss in the 1 milligram dose only. Unfortunately, no significant difference in the time to 3-month confirmed disability progression was noted with either ozanimod dose as compared to interferon beta-1a in the pooled analysis of the RADIANCE Part B and SUNBEAM trials. The safety profile of ozanimod observed in SUNBEAM was similar to that observed in RADIANCE Part B. ALKS 8700 is a prodrug of monomethyl fumarate, MMF, that is rapidly converted to MMF, the active metabolite in dimethyl fumarate, that's being developed for the treatment of RRMS. EVOLVE-MS-1 is a global interventional open-label Phase 3 study evaluating the long-term safety of ALKS 8700 in about 930 patients with RRMS. Preliminary data from the ongoing trial presented in Paris showed that ALKS 8700 is generally well tolerated, with a low rate of GI-AEs and no serious GI-AEs were observed during the first month of treatment. Long-term results from this study in the EVOLVE-MS-2 trial will provide safety and tolerability data on the use of ALKS 8700 in patients with RRMS. The efficacy of cladribine tablets, 3.5 milligrams per kilogram, cumulative dose given in short courses annually for 2 years, has been demonstrated in patients with early MS in the ORACLE MS study and in patients with RRMS in the CLARITY study that was maintained in the CLARITY extension study. The most common AEs in CLARITY and its extension were lymphopenia. A large number of posters on cladribine was recently presented at the 7th Joint ECTRIMS-ACTRIMS meeting. For example, a subgroup analysis of CLARITY showed cladribine produced statistically significant effects versus placebo on gadolinium-enhanced lesions, active T2 lesions, and cumulative combined unique lesions in patients with high disease activity. In addition, a post-hoc analysis showed that compared to the overall CLARITY study population, high disease activity subgroup had higher odds of achieving NEDA with cladribine versus placebo. Moreover, data from CLARITY, its extension study, in the Premier registry shows that lymphocyte recovery begins soon after treatment with cladribine tablets in year 1 and year 2 in patients with MS. In addition, data from the integrated safety analysis of cladribine tablets clinical trials showed that severe lymphopenia resulted in an increased frequency of infections, but did not have any differential effect on the type of infectious AEs. Now let's discuss some of the emerging monoclonal antibodies for the treatment of relapsing MS. The Synergy trial was a phase 2, 72-week, parallel group, dose-ranging study designed to assess the efficacy and safety of the anti-LINGO monoclonal antibody Observational versus placebo in relapsing forms of MS when used concurrently with interferon beta-1a intramuscular. A statistically linear dose response was not observed with Observational versus placebo. An analysis showed an inverted U-shape Observational dose response, with more favorable outcomes in the 10 and 30 milligram per kilogram dose groups. However, a post-hoc analysis presented in Paris identified a potential patient subpopulation who may benefit from Observational treatment. The consistency of findings across clinical and MRI endpoints in the subpopulation together suggest that Observational could be developed as an add-on therapy to disease-modifying therapies. Now let's discuss some therapies that are currently under investigation for the treatment of progressive forms of MS. The EXPAND study demonstrated that siponimod, a selective modulator of sphingosine-1 phosphate receptor types 1 and 5, significantly delayed confirmed disability progression in patients with SPMS. Additional data from the trial presented at the 7th Joint ECTRIMS meeting showed siponimod significantly reduced MRI activity and slowed brain volume loss in patients with SPMS already at month 12, and effects were sustained at month 24. In addition, an exploratory multi-state model indicated that siponimod reduces the risk of confirmed disability progression independently from on-study relapses. Now let's discuss MD1003. MS-SPI was a 12-month, randomized, double-blind, placebo-controlled trial studying the effects of MD1003, high-dose biotin, in patients with progressive, non-clinically active MS. In this open-label extension, all patients received MD1003. In the MS Paris 2017 meeting, the results of the brain volumetric MRI follow-up sub-study showed volumetric analyses performed independently and blindly by 2 different reading centers indicated a decrease in the loss of brain volume and gray matter volume in the MD1003 arm as compared to placebo. A decrease in the loss of these volumes were also observed in the placebo group switching to MD1003. No difference between groups was observed at month 24, after the placebo arm had been switched to active treatment. And finally, GLD52 is a next-generation humanized anti-CD52 monoclonal antibody being assessed for the treatment of MS. GLD52 targets an epitope that is distinct but overlapping with the epitopes targeted by alemtuzumab. At the 7th Joint ECTRIMS-ACTRIMS meeting, data from a randomized, single ascending dose trial in patients with progressive MS was presented. The results of the study showed both IV and subcutaneous GLD52 induce robust, dose-dependent T and B lymphocyte depletion in a pattern similar to that of alemtuzumab. Most AEs with GLD52 were mild infusion or administration-related reactions. The absence of severe, serious infusion or administration-related AEs with or without steroid premedication was consistent with an improved tolerability profile. Further studies will characterize lymphocyte repopulation and the potential of GLD52 to rebalance the immune system. Only a few years back, 1993, the very first MS disease-modifying therapy hit the market. Look where we are now. There has never been a better time to be beating up on MS than today. And we have just seen an exciting wave of new therapies, which we'll be testing over the next several years. It's a great time to be fighting against MS. Recently presented data continue to add to our breadth of knowledge on the efficacy and safety of conventional injectable DMTs for relapsing MS. New analyses of recent clinical trials and their extension studies provide new insights into the long-term efficacy and safety of approved oral disease-modifying therapies. Late-breaking data on approved monoclonal antibodies provide additional understanding in the potential benefits of these therapies with respect to their effectiveness in early disease, durable efficacy, and safety in patients with MS. There are also a number of emerging disease-modifying therapies in various stages of development for the treatment of either relapsing or progressive forms of MS. It has not yet been determined how these potential advances might fit into the current treatment landscape. That ends our discussion for today. I hope you found it informative and useful in your practice. I encourage you to download the slides and practice aids from this activity, which include summaries of additional data not discussed during this presentation. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/SQK. This activity is supported by educational grants from Biogen and Sanofi Genzyme. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.